Beta-hydroxybutyrate is definitely the best indicator there. And if that's not available, I would probably just use the anion gap.
Welcome to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are so excited to be sitting down and speaking with Dr. Nicole Glaser today on severe DKA. Will you please get things started by telling us about yourself, including something you enjoy outside of medicine?
Yeah, so as you mentioned, I'm a pediatric endocrinologist, and I'm a researcher with a long-time interest in DKA. I work at UC Davis in California, but I've been involved in lots of multi-center collaborations in the U.S. Let's see, outside of medicine, I love exercise. I do boot camp fitness classes about 3 or 4 days a week with a group of friends who've been exercising together for about 15 years or so. I also love spending time with my husband and our 3 daughters, and we officially became empty nesters as of this fall with our youngest starting college. So that's kind of weird and fun stage too.
Oh, absolutely. So as you mentioned, you've run multi-center trials and collaboratives in the DKA space for a while. You're also the division chief. I'm curious, did you become interested in endocrinology because you saw the research questions, or was it endocrinology first and then this huge research area within it?
I think definitely the research question was something that pointed me in the direction of endocrinology. When I was a resident, I was actually trying to decide between peds cardiology, critical care, or endocrine. And we actually had a case when I was a resident in which a child with really severe DKA developed cerebral injury. And at the time, I was really puzzled by why it had happened. And it was, kind of a devastating event for all of us residents. And I remember going to the library. We did that back then. Not everything was online. And
that's a website, right?
Yeah. And, going through every journal I could find that had articles on cerebral edema and in DKA, and just feeling like the explanations were really unsatisfying and didn't make sense in regard to the patient that we had. And I've been fascinated by the topic ever since. And so I think that pointed me in the direction of endocrinology and exploring it from the diabetes endocrine side of things.
Oh, that's so impactful that you were motivated by that patient and by the questions in the field.
We're excited that you followed your passion. This question that you had as a trainee, it sounds like that's still something that we think about quite a lot, mechanisms of cerebral injury and DKA. As we move closer to getting into our discussion for the day, any relevant conflicts of interest?
No conflicts.
All right. Allison, give us a case.
Let's do it. Dr. Glaser, we're going to give you a transport call for a 4-year-old boy with what sounds like new onset DKA. You confirm the history of polyuria, polydipsia, and weight loss. On presentation, his VBG showed a pH of 6.9 with adequate respiratory compensation, a serum bicarb of less than 5. Blood glucose is 550, and on physical exam, the patient is tachypnic, tachycardic, normotensive with delayed cap refill. He is opening his eyes to voice and localizing pain, but he's not speaking or obeying commands, and he quickly is falling asleep. So really, to get us started here, we've given you a new onset DKA, 4-year-old patient with marked dehydration, age less than 5, and a GCS of 13. How are you triaging this patient, and what clinical information are you using to classify the DKA severity and risk?
Yeah, so according to most criteria or most guidelines for DKA, for example, like the ISPAD or International Society for Pediatric and Adolescent Diabetes guidelines, DKA severity is usually defined by pH. So anyone with a pH less than 7.1 would typically be falling into the severe category. In truth, I think that's a fine classification, but I think that there are other factors that are worthwhile to take into account when you think about severity. So for example, some children have really high glucose levels in addition to very low pH, which is a situation that is either termed hyperosmolar DKA, or some people call it mixed presentation of DKA and HHS, or hyperglycemic hyperosmolar syndrome. But those kids are actually the most severely ill of the children we take care of, because they both have the issues of DKA and acidosis, but also have the really severe electrolyte deficits and severe dehydration of someone who has HHS. So I think there are multiple factors, but technically pH is probably the most important one for severity.
And, this patient here, of course, has the severe acidosis with a pH of 6.9, has this altered mentation. When this child comes into the emergency room resuscitation area, or perhaps even in the ICU, we're worried about this patient either already having some cerebral injury or being quite preoccupied about his risk of developing cerebral injury. If you're on the phone with the transport team, they're evaluating this patient, about to bring him up to the ICU or bring them to our institution, how do you think about that child's risk of cerebral injury, and how does that influence maybe the recommendation for hyperosmolar therapy in this acute setting?
Yeah, so that's a really good question. And I don't think there's really an evidence-based answer to give, since there are, as we know, no randomized trials or definitive studies of mannitol or hypertonic saline for patients who present like this. For understandable reasons, that trial would be probably nearly impossible to do. But in the case of this patient, he's severely dehydrated, with the delayed capillary refill time. And probably what I would tell them is to try giving a fluid bolus first and then reassess mental status. And if we didn't see improvement, then at that point we could consider hyperosmolar therapy, although I'm curious to know what both of you would do.
Ooh, I really appreciate your answer of just a quick question. Have we started with fluid resuscitation at all? Like, how many minutes has he been in your institution, and have we been able to get that first bolus in? I wrote this question. I need to think about the care setting on the phone, but I would lean towards yes. Every transport call, you get a certain amount of minutes with the doctor at a certain expected callback time. And so I think that if it was suboptimal conditions, I would probably just say you should do this and you should do this. If you're considering scanning the patient, you should get that going before you put them in the scanner. Zach, what about you?
I can't say there's a practice pattern that our division has that's been explicitly defined and communicated. Yeah. I think trajectory of illness is probably what gets my closest attention. So this is a patient that came in with a GCS of 14, and maybe they've gotten some fluid resuscitation. Maybe they've gotten some particularly aggressive fluid resuscitation. And maybe if that patient is worsening, I would be much more likely to give hyperosmolar therapy. If the patient came in, they had a GCS 10 or 11, and then they resuscitate the child, they give us a call, our transport team goes out there, and the GCS is about the same, probably would be less inclined to give that child hyperosmolar therapy. I think, just getting an accurate neurologic exam over the phone is so challenging.
Yeah.
And there can quite easily be discrepancy in what you hear from the first practitioner to the second practitioner. So I think, having someone who's following that child closely and personally is the best way to actually know if the child is getting worse or not.
Yeah. What do you guys think about CT?
CT is an interesting topic in these kids too, because there are studies showing that children who are diagnosed with quote unquote DKA-related cerebral edema often actually don't have edema on initial imaging studies. In fact, there was a study showing that about 40% of children who met clinical criteria for that diagnosis, DKA-related cerebral injury, didn't have edema initially, but then hours or even sometimes days later would develop edema. So, for one thing, decision-making about hyperosmolar therapy, as I think Alice already mentioned, shouldn't depend on imaging. That's, one thing that I think is fairly clear. I do think there's still a role for imaging. There's other intracranial pathology that can happen in kids with DKA. For example, cerebral infarction, cerebral hemorrhage has also been described in DKA, and you'd certainly want to know if that was going on. And then, of course, in children who have really severe mental status alterations where you'd worry about herniation or impending herniation, then that's kind of a different story. But in this particular patient, I don't think I would be inclined just yet to do a scan.
Yeah, I think wise comments, right? If the diagnosis is clear and the child is protecting their airway, I worry that either locally and other places that I've worked at, I worry that we do lots of scans in these kids and don't necessarily add value to the care. Certainly, there's going to be that minority of patients that you're going to find something really impactful. And, we have to just lean into the uncertainty here and make the best decision for the patient in front of us. You've already introduced us to almost a knee-jerk reaction is when these kids are altered to say they have cerebral edema. And that might not be the case. Will you tell us more about what is the pathophysiology here of cerebral injury in DKA?
Okay, so that is a difficult question to answer because, for one thing, we don't fully understand the pathophysiology of cerebral injury in DKA, but also what we do know about it is a topic for about an hour or two of lecture.
Nice.
Yeah, I'll try to put it in a nutshell as best I can. For one thing, we know that it's much more complicated than it was thought to be in the past. So past hypotheses basically attributed cerebral injury in DKA to osmotic change during treatment. So the idea was that you gave rapid fluid infusion or too much insulin or something like that, and there were rapid declines in glucose that then caused brain cell swelling and increased ICP and brain injury as a result of that. So that hypothesis was kind of appealing and simple and nice, and people really jumped onto that. But then over the years, the evidence really pointed away from that as the cause. So if that's not the cause, then what is? So that's the part that we're, just now slowly starting to figure out. Most of the current data point to cerebral injury being related to hypoperfusion and reperfusion injury in the brain, along with the hyperinflammatory state that happens during DKA. So we know, for example, that there are all kinds of inflammatory mediators that are extremely high in patients with DKA, including, for example, matrix metalloproteinases that are known to disrupt the blood-brain barrier and then expose the brain to inflammatory and toxic substances that are circulating. So while we don't fully understand the pathophysiology, at least I think we can say that current evidence points to inflammation in combination with perfusion fluctuations as the important factors. And we really have quite a bit more work to do before we sort the rest of it out.
Oh, wow. The endothelial injury is fascinating, and I'm sure a huge, huge, huge rabbit hole. Can I ask, as we sort of, we give the 5-minute spiel for our residents on rounds, when you think about hypoperfusion in a DKA patient, you have endothelial injury, but also the dehydration and then the low carbon dioxide from compensatory hyperventilation. How do you parse those two things apart?
First of all, people often ask, well, if reperfusion injury is the issue, should we be doing something different as far as fluid administration or reperfusing the brain? And there's first of all no real evidence to say one way or the other what we should be doing. But I don't think that there's any evidence suggesting that doing something different as far as fluid infusion would make it less likely to have reperfusion injury. I think at some point you're going to reperfuse the brain, and whatever's going to happen is going to happen. So, if they have severe dehydration, you should go ahead and treat that basically as you would any other dehydrated child. And I know we're going to talk later, I'm guessing, about the PCARN fluid study. So we'll get into that at some point.
As reflecting on what you mentioned for the answer to the previous question, it seems like over the course of perhaps, a few decades, the initial hypotheses for mechanisms in cerebral injury were that of effects of treatment. Being like there was concern that rapid fluid shifts from the care that we deliver directly causes cerebral edema and cerebral injury. And it seems like in the more recent time, there's much more thought about the degree of the patient's illness at time of presentation being more directly related to cerebral injury. Is that correct?
Yeah, that's absolutely correct. And in fact, we did publish some data a few years ago looking at children who came to the emergency department with cerebral injury that was either present when they first presented or developed within an hour or so of being in the emergency department. And we found that the risk factors in those children were the exact same ones as the risk factors for children who developed cerebral injury hours into treatment. So that really suggests that it is the pre-existing condition of the child that seems to be the most important driver.
And as a follow-up there, it seems that if you don't mind, you'll share some of these risk factors. I imagine you were going to say low carbon dioxide levels, high BUN, a number of other things. And then if we identify those factors, do we know about any kind of change in our management?
That's exactly right. So the main risk factors are very high BUN levels and low PCO2, and low pH. Those are the main things. There's some studies suggest that younger age is also a risk factor, but mainly that tends to be because younger patients present more severely ill. So they have some of those other risk factors. But yeah, those are the things to look out for. Those are the patients we would be most worried about if someone has really high BUN, low PCO2. And as you alluded to, yeah, we don't know of any changes in therapy that could prevent or mitigate development of cerebral injury. I think just being aware that the person's really at risk and having a mannitol kind of ready to go if things worsen is about as much as you can really do.
So let's get back on our clinical pathway here. Say this hospital is asking about the number of fluid boluses they should give. 10 per kilo, 20 per kilo. We maybe have a lactate. We're thinking about a third bolus. What matters here? What should we recommend?
Certainly in the ED or wherever they present initially, most children should get an initial bolus, almost anybody with DKA, of 10 to 20 mLs per kilo of normal saline. And the bolus can certainly be repeated if there's still evidence of poor perfusion. Again, that's something we learned from the PCARN fluid study, is that we should basically be treating these kids just like other kids with dehydration and basing some of what we do on response to the initial bolus and clinical judgment.
A clinical question that I have here, it's pretty common kids that are coming to us have severe DKA and they're quite dehydrated. And of course, there's a continuum, a spectrum there of illness. And these kids will commonly have evidence of poor perfusion. And then the emergency doctors do a great job of getting that first bolus in. And I don't necessarily know if I have like a really clear practice pattern for when there's ongoing evidence of hyperperfusion or shock after a fluid bolus. Part of me wants to do the minimal possible to theoretically lower the risk of cerebral injury and just put them on that next continuous infusion of fluids. But the resuscitationist in me wants to fix the ongoing shock. Do you have any insight into how to approach scenarios like that?
I would be reassuring on the side of rehydration and addressing impending shock or compensated shock or whatnot, because so far there really isn't any evidence that we're harming kids by giving fluids a little more rapidly than they've been given in the past. In fact, I'll share something from, again, it was kind of a sub-analysis of data from the PCARN fluid study. We didn't publish this because the data set was small, but we did look at, we had a few patients enrolled, I think about 20 or something like that, that presented with fairly severe mental status changes where they would probably meet criteria for diagnosis of cerebral injury and DKA presentation. And we did look at which arms those kids were randomized to and whether we saw differences in how fast they recovered in terms of mental status. And actually, the group was small, so none of the differences were statistically significant, but the ones that were given fluids more quickly actually had a little better trajectory in terms of improvement of mental status during treatment. So we couldn't detect any harm from them having been in the more rapid fluid infusion arms. So I would probably err more on that side personally. But again, it's something about which it would be great to have more data.
Oh, absolutely. At intensivists, we like it when a study says, no, every single patient we looked at in the discussion or in supplemental or just chatting, we really didn't find any evidence of injury, right? Like even in these 20 where I just sat down with the spreadsheet and really looked. So I appreciate that. So this PCARN fluid study, this is a large multi-center trial that you ran titled Clinical Trial of Fluid Intervention Rates for Pediatric Diabetic Ketoacidosis, and was published in New England Journal in 2018. Do you mind walking us through sort of the structure of what you did and what you found?
Sure, of course. The PCARN fluid study was a large multi-center randomized trial, as you mentioned, comparing basically 4 fluid treatment arms. So we had 2 arms that used normal saline and 2 arms that used half normal saline. And then within those 2 different fluid types, half of the patients received fluids at a faster rate, and then the other half at a slower rate. And in the trial, we looked at both short-term neurological outcomes, that is mental status during DKA, which we measured with GCS scores and also with some more detailed tests of mental status. And then we also looked at long-term neurological outcomes with cognitive testing done several months after the kids recovered from DKA. And what we found was that there were really no significant differences among the arms in any of the outcomes. So interestingly, again, getting back to what you were mentioning before, among the sickest patients, so those who had pH in the lowest quartile or glucose in the highest quartile and so forth, we actually saw trends towards a little better outcomes with more rapid fluid infusion, so more rapid recovery of mental status or less deterioration in mental status, although the differences were just short of statistical significance. So this annoying p-values of 0.06 or 0.07. But that was the direction in which the trend was pointing. So certainly the trial provided evidence that more rapid fluid infusion is not harmful. We can't really say for sure that it's beneficial, but the trend was pointing in that direction.
Oh, thank you. Can I ask, just when we think about the low infusion rate and the high infusion rate arms, if you had to give us, I know you did it based on estimated dehydration, but was that closer to 1.5 maintenance? Was closer to 2 times maintenance? What was your high infusion rate?
It was probably a little, I'd have to go back and calculate, but probably a little in excess of 2 times maintenance.
Wow.
Yeah. So it was fairly rapid. There was a pretty good difference between the two rates, for sure.
It's huge. And one of those arms was high infusion rate, half normal saline?
Yes.
Wow.
Yeah.
That's huge.
Mm-hmm.
So you have this large trial, and it compares isotonic and hypotonic fluids, faster rate, slower rate, no significant difference on cerebral injury. When you have that study, which stands above, as I understand, all of the other studies in the area, and then you have the studies that are subsequent to that, how has that affected clinical practice? One interpretation could be you could do whatever you want. As long as it's reasonable, they're going to do okay. Or have we seen practitioners, say, hey, if we resuscitate these kids fast, sufficiently early on, and that could perhaps shorten their hospital stay, what has practice done since then?
I do think people have become a bit more liberal. Before the PCARN fluid study was published, there was a lot of guidance on DKA about limiting fluids, give the initial bolus over an hour instead of 20 or 30 minutes, rehydrate over 48 hours, use the minimum fluids, try not to bolus, things like that. Some of those things have largely disappeared from protocols. I know the ISPAD guidelines now suggest giving a larger initial bolus and giving it over 20 to 30 minutes and allowing for that range of rates of fluid resuscitation. So providing fluid replacement over 24 to 48 hours with a range of possible fluid types. So there's a lot more room for judgment, again, within the range that was used in the PCARN fluid trial, because of course we can't say anything about rates that were higher or lower or other fluids, things like that.
No, absolutely.
These children, their metabolic acid-base disturbances is quite complex. They, of course, have their elevated anion gap acidosis from their ketones, but as their resuscitation progresses, pretty common to have a non-anion gap feature, perhaps even hyperchloremic excess. So with that context, how do you typically recommend resuscitation fluids and maintenance?
I'm wondering if you have an opinion on lactated ringers, maybe some sodium acetate containing fluids like Plasmolite, things like that.
Yeah, well, great question. And I would really love to see a big randomized trial comparing something like lactated ringers or Plasmolite to normal saline and DKA. So if anyone wants to do that, that's listening, great idea. I support you in that. But unfortunately, right now, there's no real data out there except for some very, very small studies. I can tell you that at our center, we do use acetate as part of our potassium replacement. We use a mixture of K-phos and K-acetate, again, to try to cut back on, as you mentioned, the chloride load, which leads to hyperchloremic acidosis in a lot of patients. And, we think that works fairly well. But again, nice big randomized trial would be amazing.
Mm-hmm. Mm-hmm.
So the general practice here for resuscitating patients with DKA, they get their fluid boluses, ensuring adequate peripheral perfusion. And then typically a DKA type maintenance fluid is ordered, and commonly we'll have electrolytes repletion as well. After ensuring there's adequate potassium, that's when an insulin infusion is typically started. We'd love to know that your general practice here for titrating insulin infusion rate, and does clinical context make a difference on what insulin dose you would choose?
Yeah, also a good question. And again, one where it would be great to have a really large study. I think there are some small studies comparing the typical rate, which is 0.1 units per kilo per hour of insulin versus something less, usually 0.05 units per kilo per hour. I don't think that there's great data one way or the other to guide us as far as which one is better. As far as our own practices, we do occasionally use slower insulin infusion rates for kids that we anticipate being very insulin sensitive. So very young children, for example, can be particularly sensitive to insulin, and the glucose declines really quickly and acidosis resolves well with a lower rate. So occasionally we'll use a lower rate there. Or the other group where it makes sense to consider a lower rate is children who present with hyperosmolar DKA, or that mixed picture of DKA and HHS we talked about before, where they're not terribly acidotic, but they are more towards the HHS end of that spectrum. In those kids, you don't really want to drop the glucose level too quickly until you have a lot of fluid resuscitation on board, because you're going to contract the intravascular volume as the glucose drops. So, for those kids, it also potentially makes sense to use a slightly slower insulin rate. But I think the most important thing really is that whatever you do, you're monitoring to make sure it's working the way that you want it to. So if you're going to use a slower insulin infusion rate, you got to be really sure that acidosis is improving and ketosis is clearing and things like that the way that you're intending. And if not, then you need to adjust.
Can you explain further about contracting the intravascular volume as your glucose drops or as you lower your glucose levels with insulin?
Yeah. So when someone has a very high blood glucose level, glucose acts, of course, as an osmolyte. So it's pulling water, holding water into the intravascular space, which is the reason that patients with DKA often, despite severe dehydration, don't necessarily have poor perfusion or some of the signs of dehydration you might expect, because intravascular volume is relatively preserved. But as the glucose level drops, as glucose goes down, water is also going to leave the vascular space. So you can have the situation where the glucose level drops, but you haven't given a lot of fluid resuscitation. Perfusion can be worsening, or you can even, in really severe cases, potentially cause shock in someone because of lack of sufficient fluid administration as the glucose level is declining.
Oh, thank you. And then I think that this is a similar line of reasoning, but Zach and I are asking you, okay, we're doing 0.1 units per kilo per hour. Should we go slower, 0.05? Why aren't we giving more insulin up front? Why not go higher than 0.1?
Well, there aren't great data looking at a range of insulin infusion rates. Long ago, the rates that insulin was administered in DKA was actually substantially higher. I mean, we're talking like decades ago in DKA. And at some point, someone did a study looking at 0.1 units per kilo per hour versus, I don't remember what the standard was, but it was quite a lot more than that back then, and showed that acidosis resolved just as quickly, but there were lower rates of hypokalemia and hypoglycemia during treatment. So 0.1 units per kilo per hour back then was called low dose insulin infusion. But that's really been the only major investigation of insulin dosing in DKA. So I don't think we can say whether slightly more than 0.1, slightly less. I think we just really don't know what the optimal is.
It's always interesting how integers and whole numbers are so influential in medicine. A milligram of epinephrine is the perfect dose in cardiac arrest, right? For the adult-sized patient. 0.1 of insulin, it's got to be perfect.
Exactly.
In our sickest kids with DKA, this could be a localism here, but there can be some focus on not dropping the glucose too quickly. In a very minority of cases, insulin might be titrated to meet that. Usually just giving more dextrose fluids is the way to go there. Is there any evidence that dropping a glucose, quote, too quickly, maybe arbitrarily more than 100 points an hour, is there any evidence that actually could influence outcomes, or is that just localism?
So that's a complicated question to answer. In the scenario that we talked about before, where someone does have extremely high glucose levels, like more towards the HHS end of the presentation spectrum, it is reasonable to try to drop the glucose level slowly, but not for the reasons that most people think, more because of changes in intravascular volume and potentially triggering poor perfusion of the kidneys and other organs and things like that. As far as causing cerebral edema, which is where everybody is always worried about dropping the glucose level too quickly, there's really no data whatsoever to suggest that. And in studies that have looked at risk factors, the initial glucose level is really never been identified as a risk factor or, a higher initial glucose. Same thing with the decline in glucose. When that's been looked at in studies of risk factors for cerebral injury, the decline in glucose never seems to be associated either. And interestingly, children with HHS, straightforward HHS, almost never develop cerebral injury. And you would think they would be at the greatest risk if osmotic changes and glucose decline potentially were a risk factor. So I don't think there's anything to worry about in that regard, although from the intravascular volume and perfusion standpoint, it is worthwhile thinking about it in that sense.
Oh, excellent. Thank you. Now, before we were talking about fluids, we're talking about avoiding hyperchloremic metabolic acidosis, getting things corrected. We're adding acetate to the fluids. We're wondering if we can add a little more acetate to the fluids. We're getting close to a bicarb bolus here.
No, we're not.
There's a storied history. There's a storied history here with bicarb and DKA. Could you tell us a little bit about that?
Yeah, sure. So basically, our group many years ago did a retrospective study looking at risk factors for cerebral injury, and we did find that administration of bicarb was associated with higher risk of cerebral injury after correcting for DKA severity and other factors that might influence whether or not a person got a bicarb bolus or bicarb treatment. So that argued against bicarb use. Interestingly, as far as how this all works from a pathophysiologic standpoint, going even further back in DKA research history, long ago, there was a study of adults where they actually randomized adults to either DKA treatment with bicarbonate or without bicarbonate. And they did serial lumbar punctures, which is, amazing. Whoa. That people were willing to participate in that study, but somehow they did. And they found that bicarbonate-treated group had progressive acidification of the CSF during DKA treatment, which does make sense because when you treat someone with bicarb, their PCO2 goes up and CO2 crosses the blood-brain barrier very easily and generates carbonic acid in the CNS. So it makes sense that that would happen, but they were able to actually show that it happens with typical bicarb treatment in people with DKA. So we don't know for sure that is necessarily the root of the adverse outcomes with bicarbonate treatment, but it certainly doesn't seem beneficial. We'll say that. So most current guidelines recommend against using bicarbonate in children with DKA, unless they have some very rare circumstances like life-threatening hyperkalemia, for example, where you would need it for other reasons, or extremely severe acidosis where they were hemodynamically unstable and you thought that was related to the severity of the acidosis.
Almost all of our patients with DKA, they come in acidotic, but they get resuscitated, and they get better, and they perhaps leave the ICU in 1 or 2 days. There are a minority of patients, though, that can develop multi-organ dysfunction. Do you have a particular, maybe like clinical presentation that worries you more from multi-organ dysfunction? And if this kid is sicker, do you have a set of studies that you would ensure is completed on these kids, worried about, of course, kidney dysfunction and maybe even DVT risk, among others?
Yeah, so that's a great question. And I don't think there are really good data in the literature to answer it, but my guess would be that the risk factors are probably the same as the ones we talked about for cerebral injury. And I say that because recent data actually suggests that cerebral injury and kidney injury seem to be linked in DKA. For example, in the PECARN fluid study data, when we looked at kids who had developed acute kidney injury during DKA and those who didn't, and after adjusting for severity factors and demographics and other things, those who had developed acute kidney injury had poorer outcomes on cognitive testing after they recovered from DKA. So that suggests, among other things, that brain and kidney injuries maybe come together as a package. So if I had to guess, I would say that it's going to be those same risk factors to look out for, very low pH, low PCO2, high BUN, where I would really worry about a patient heading in the direction of multiple organ injuries.
Yeah. All right. So thank you so much for the acute management stuff. Let's walk you through hospital day 2 here and see what you think. So on the morning after admission, you got a 4-year-old patient, new onset DKA. Your morning gas has a pH of 721, a bicarb of 15, and a chloride of 125. He's now opening his eyes spontaneously, answers questions, looks good. His parents are still thinking we're not going to be able to convince him to eat breakfast. Your resident asks if we can still transition him to subcutaneous insulin, and also if you're able to sort of put a continuous glucose monitor on him, like what, as we start to think about home, what are the options in 2025? Before we get into that, let's talk about how you trend your labs when a patient is improving and on their insulin infusion 2-bag method.
Yeah, so typical guidelines would usually recommend checking glucose hourly while a person's on an insulin infusion, and then venous blood gas and electrolytes like every 2 to 4 hours. Generally, I would say it's a good idea to check electrolytes on the more frequent end of that 2 to 4 hour window for kids that either have like a very prolonged history of polydipsia and polyuria, where you're worried that they've been losing electrolytes for many weeks, would have a really big electrolyte deficit, or those who are, again, towards the side of hyperosmolar DKA, where the glucose level is super high. And those kids are known to have bigger electrolyte deficits also, particularly potassium and phosphorus. So those would be the usual things to monitor.
Nice. Our perception is that there's some clinical practice variability here, and we're really wondering what you think is the best for a United States PICU streamlining care. I'm hearing electrolytes every 2 to 4 hours, that you could do BMP and gas, and then there are different variables that you can use to say my patient is now out of DKA, right? Like you can look at the pH, you can look at the bicarb level on the BMP, you can look at the anion gap, you could draw serum beta-hydroxybutyrate or something. What do you consider really the gold standard and best for streamlining care?
Well, some things I think are pretty standard everywhere, like checking glucose hourly and whatnot. I think the most variability is in the frequency of electrolyte assessments and how frequently, particularly calcium, phos, and magnesium are checked. Some protocols roll those into the electrolyte checks. Some have them less frequent. Some don't check them at all.
Interesting.
I think recently more hospitals are using routine phosphate replacement as part of their DKA protocols. So for that reason, they're checking phosphate and calcium levels a little more often. And that's what we do at our center too, that we check those routinely with each of the 2 to 4 hour electrolyte tests. I think the other thing that, again, kind of state of the art, and I would recommend if it's a rapid turnaround time at your hospital, is to measure beta-hydroxybutyrate in the serum. That's definitely the best and easiest indicator to look at for resolution of DKA. So not all hospitals have that where the turnaround time is rapid enough for it to be useful. But if it is, that's probably the easiest one to look at because it avoids the problem of using the bicarb where hyperchloremic acidosis is going to throw that off, and then having to make a decision about whether to transition to sub-Q when the person still seems a little acidotic because the bicarb's still a little bit low. So beta-hydroxybutyrate is definitely the best indicator there. And if that's not available, I would probably just use the anion gap, which is next best.
Nice.
You're saying things we love to hear. Like the acidosis diagnosis here is so messy because like you can look at the pH on the gas, and it's usually a venous gas. So therefore, it's going to be a touch more acidotic than your arterial gas. You have the combination of perhaps the anion gap acidosis if the ketones are not yet being metabolized and treated with insulin. Of course, that hypercholemic acidosis is always going to be there for in a hospital setting. And then the ketones in the urine tend to last for a long time. And I just always feel like in the ICU, we're a bit too focused on fixing current problems in front of us. We're not as good as like education. And I feel like many of these patients and families need the education. And I think the beta-hydroxybutyrate is the best way to identify, we're really making great progress here. This patient is, if their beta-hydroxybutyrate is normal, we could probably say with pretty high certainty, they could be safely transitioned off insulin infusion and work on that education piece.
Yeah, absolutely. I think that's really the way to go.
Oh, and you guys can get that every 2 hours, every 4 hours?
Yeah, about the same as the chem panels. Mm-hmm.
Nice. And then do you guys also check venous blood gases every 2 to 4 hours? Or is it once we're getting BMPs? And these are some patients that are doing well. Like once we're getting BMPs, we're good. Or once we're just sending electrolytes, we're good.
Well, we do initially still check a VBG towards the beginning of treatment, but I think once they are getting to where DKA is nearly resolved, it's probably unnecessary at that point.
Nice.
Tell me more about your practice with using when to incorporate long-acting insulin, like Lantus perhaps. Is this something you would do around time of hospital admission to the ICU, or is this something you wait for that transition?
Yes. Well, another topic that's really crying out for someone to do a large RCT and tell us with some definitive statistics what the risks and benefits are. There's a lot of different opinions about that. Some people do, some people don't. Even within our own endocrine group out here, some people are bigger proponents than others. There are some small studies comparing adding basal sub-Q insulin earlier on in treatment versus just at the time of transition. And they do suggest that the resolution of acidosis is a little faster. The risk of rebound hyperglycemia after stopping the infusion is a little less. There's also maybe a little bit higher risk of hypoglycemia during treatment. So it's kind of a mixed bag. I personally feel like there is one circumstance where it's probably easier to start the basal insulin ahead of time, which is when you anticipate that the person's going to transition to sub-Q in the morning. Most families don't like to give their basal insulin in the morning. They want to give it in the evening or at bedtime. So if you have to give it in the morning when they transition, then you're going to have to slowly adjust the timing of the basal insulin over several days, which is a big hassle. So you can save everybody lots of hassle by giving the basal sub-Q the night before if you're thinking it's really likely that this person is going to start sub-Q in the morning and stop the infusion then.
Oh, nice. Okay. So evening Lantus is kind of the goal for at least your patients' families, like in your experience.
Yeah, that's when most people will give it, and it's more convenient for them. So that makes the most sense.
That's good to know. All right. Let's see. Okay. We've also given you kind of a small kid who presumably hasn't gotten a long-acting insulin and he doesn't feel like eating. How do you approach the transition in that setting?
Yeah, well, theoretically, you should be able to give just the basal insulin, and whether or not they're eating, they shouldn't go back into DKA. That said, it's a bit tricky to get the doses right initially. Kids are a bit more insulin resistant during and after DKA than they would normally be. So traditional calculations for how much insulin a person would need for a certain age or size often underestimate what they're going to need just right after DKA. So we do still, even when we're dosing someone perfectly, we do still see some rebound hyperglycemia often because it's difficult to get a good handle on the extent of that. But if the patient were out of DKA, and as Zach was mentioning, we really want to get them started on education and learning what they need to know, I probably would still go ahead and transition and then just do correction doses of sub-Q insulin if you needed to.
Nice. Not a hard need for a full meal.
Yeah.
No, I'm also wondering, and sort of being very in this space of pediatric inpatient endocrinology and looking at time moving forward. Over the past 10 years in fellowship, I was putting Dexcoms on some cardiac ICU patients that needed insulin infusions, right? Mm-hmm. What are we expecting in terms of continuous glucose monitors, either during the acute DKA setting, getting it for everyone before they go home? What's the culture here?
It's interesting you asked that because I did notice recently I've seen a few small studies using CGM during DKA as a monitoring tool. I don't know that that's become a standard as yet, but I have seen a couple of studies where they did try to do that. You know, we do, of course, like all of our patients to use CGM ongoing. So certainly as soon as they're out of DKA and as soon as the family agrees that that's a tool that they want to use, we recommend starting CGM for sure. It's a wonderful tool for glycemic management.
Excellent. As we wrap things up here, we really appreciate your expert perspective on all of these things. Is there anything you want to reinforce for the PICU team as we wrap up?
If I had to choose one thing as a recommendation, I would say that monitoring and reassessment is really the key to happiness in DKA. I think DKA tends to be a very protocol-driven treatment. And there is a bit of a tendency to start the protocol, the patient's plugged into the protocol, and then not really think that much about it after that. And I'll say that in the cases I've seen where adverse events happened, often there were some clues about that in the hours before. You know, the trajectory wasn't quite what you would want. And you could see the patient heading in that direction, but it wasn't really noticed, in part, again, because I think when someone's on a protocol, there isn't as much thinking about how or if we should adjust. So I think monitoring to make sure that you're seeing a gradual positive fluid balance, the acidosis is gradually improving, the potassium and phosphate trends are what you think they should be and not heading too far in the wrong direction. Those things are really super important, even though the person is on a protocol.
I agree so much. Generally speaking, protocolized care in the ICU improves care, gets kids weaned on the ventilator, helps us extubate them quicker, generally moves things forward regardless if it's in the middle of the night or during the daytime. But any kind of critically ill child, especially if they have risk for deteriorating neurologic conditions, I feel like the numbers on the chart, the respiratory rate, the heart rate, they do a great job of quantifying our patient's degree of potentially shock, respiratory distress. But it's really difficult to quantify other than the GCS, which is a little bit crude, subtle deteriorations in neurologic status. And we have to be at the bedside evaluating these patients until they demonstrate to us they are clearly improving. I really appreciate you bring that up. In our conversation thus far, we've already touched on maybe some next steps in literature. Is there any particular studies that we should look out for and any other particular questions that you'd like to encourage listeners to maybe consider?
Well, I think we talked about most of them. I'd love to see a trial of balanced solutions like LR, plasmolite, compared to normal saline. I think that would be really useful. It'd be interesting to see a larger trial of different insulin doses, although I feel like that's probably a little less critical. But yeah, these large randomized trials are difficult to do, but so useful because they really provide data that can be considered fairly definitive.
Oh, yes, 100%. And a career in endocrinology research, there's a huge need. I have one final question, if you're willing to share. I am so curious. Is it true that you're married to Dr. Nate Cooperman of the PCARN Network? And I have to know if you two are still doing research together.
Yes, that is absolutely true. We've been married for 31 years. And yes, we're still doing DKA projects together. We just submitted a grant to NIDDK fairly recently, actually. Although who knows these days how long that's going to take to get reviewed with the current state of NIH.
Yeah.
But yes, we are each other's best and most favorite collaborators in research and in basically everything in life.
Well, that is so cool.
I would say, what a sweet relationship.
Yeah, grant deadlines in the Glaser Cooperman household.
Yeah, I'm sure our kids felt like dinner conversations were like super boring growing up, but what can you do?
Mm-hmm. Mm-hmm.
Well, this has been a pleasure. Thank you for leaning in and discussing a pretty common diagnosis that we see in the pediatric ICU and leaning in and exploring kind of the evidence light areas and sharing your practice. Look forward to next steps and as we continue to learn more about resuscitating these patients, and excited to share this with listeners.
Great to talk to you both.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.